Good evening, respected faculties. I welcome all in Indian Menopause Society Digital Education Committee's webinar on geriatric health. We will start with welcome address. I want to invite first Chief Coordinator Dr. Shushma Verma ma'am, Chairperson IMS Digital Education Committee. She is immediate past President Raipur Menopause Society and Vice President of Raipur Obs Gynae Society.
Good evening, all of you present here. With immense pleasure and with lots of gratitude, I want to welcome you all for the 7th webinar of IMS Digital Education Committee in association with Raipur Menopause Society. The topic of today's webinar is very important, that is geriatric health. And with lots of gratitude, I extend my warm welcome to our special guest, chief guest and speaker of today's webinar, Dr. Anju Soni ma'am, a dynamic and enthusiastic president of IMS. Welcome ma'am. Your presence here today is an honor for us, and we are grateful that you agreed to share your insights over this important topic of geriatric health and graceful aging. And from bottom of my heart, I want to thank you, Anju ma'am, Bipasha ma'am, and Sudha ma'am for giving me this opportunity. With great respect, I want to welcome our guest of honor, Bipasha Sen ma'am, Secretary General IMS. Your presence here today adds depth to our webinar, and it is a prestigious thing for all of us that you are present here, ma'am. I extend my warm welcome and regards to our special guest and stalwarts of IMS, respected Sudha Sharma ma'am, Dr. Maninder ma'am, and Dr. Jyoti Jaiswal ma'am. All this have made significant contributions to IMS, and uh, uh, they forced the IMS to great height and inspired countless members like us. I want to extend my warm regards to respected Aarti Gupta ma'am, Ragini Agarwal ma'am, and my mentor and guide, respected Abha Singh ma'am, for their guidance and support for making this today's event happen. Focused to prevent chronic illness in geriatric population so that they can live a healthy lives and compress their period of illness to just before death. We have exciting lineup of lecture followed by a panel discussion moderated by Dr. Ragini Agarwal ma'am that will provide valuable insights and add to our knowledge. So now I invite Anju Soni ma'am to bless us with few words. Welcome ma'am.
Hi, good afternoon, everyone. Today I'm not going to talk much here because I have a talk lined up with me, but I would like to congratulate the whole team of Digital Education Committee, especially the whole Raipur Menopause Society for being here and managing the whole show. I know you people have worked day and night and you have collected the stalwarts from all over in Indian Menopause Society. Dr. Sudha is there, I can see. Dr. Vipasa, Dr. Maninder, and Dr. Ragini Agarwal. And you are going to delve upon few of the very, very important topics which are so near to, I think, everybody's heart today. And I would like to congratulate in advance to all of you people who have joined. And I'm sure today's webinar is going to give you a lot of different insights into the topic which we have been talking day and night. But the concept is different. The whole scenario is different. So let's come to the this whole webinar today and learn a lot of things from each other. Thank you and congratulations, Sushma.
Thank you, ma'am.
Thank you, ma'am. Now I want to invite our guest of honor, Dr. Vipasha Sen ma'am, for few words. She's Secretary General Indian Menopause Society 2024-25 and Treasurer of Indian Menopause Society 2022-2024.
Over to you, ma'am.
Thank you, Dr. Sanjita. for the introduction. I am really happy. First of all, I will thank the Digital Education Committee of, please remove the screen so that we can see each other. Okay. I first of all, I thank Dr. Sushma Farma and the whole Raipur team, of course, for today's webinar. They have organized in a nice way. And yes, geriatric health is of utmost importance, especially not only for our menopause society people, but for all right now, for all, everyone, the medicine specialist, the gynecologist specialist, for everyone, geriatric health is of utmost importance. And today the speaker is none other than our president, Dr. Anju Soni. So I am more elated that I am happy to listen to, eagerly waiting to listen to her. And I wish all the success of this webinar, today's webinar. Thank you all.
Now I invite Sudha ma'am to bless us with few words.
Thank you, Dr. Sushma, and huge congratulations as a chairperson digital education. Somebody has joined with two.
Yes, ma'am. Somehow the voice is echoing.
Yeah.
Somebody
So-
is joined by two devices.
Two devices.
So please log out with one device. Thank you.
So congratulations, and Dr. Sushma and the whole team of Raipur, Menopause Society for this webinar. And the topic is so very challenging, very interesting, especially for, for elderly people like us. And the statistics, once you go through it, they are so scary, and I am sure Dr. Anju is going to touch each and every aspect of it. We are waiting to learn, things from her. But I, learned that the pace of population aging is much faster than what it was earlier. And in 2020, number of aged people, beyond 60 years, they have outnumbered the children younger than 5 years. And it is expected that more than 80% of the older population by 2050 is going to live in countries like India. So hence, the countries like India, they face major challenges to ensure that their health care and social system, they are ready to make the most of this democratic shift. And we are eagerly waiting to hear from none other than our dear Dr. Anju Soni for this topic, and all the success to this webinar, I wish, and thank you for making me a part of it.
Thank you,
Masha.
Sudha
Thank you.
ma'am, for your wonderful
thank you.
Thank you, everyone.
Dr. Ragini.
insights.
Bye
Maninder
bye.
ma'am and
Thank you.
Bipasha ma'am for being here till the end of the
Thank you, Sudha
webinar.
ma'am. Thank you, Sushma.
Bye.
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 Beautiful
Good night, ma'am.
insights.
Thank you,
Sangeeta.
Sangeeta.
Thank you,
Thank
all
you,
of you,
ma'am.
and the
Good night, ma'am.
people for
Thank you,
making
Aisha.
this
Thank
panel
you.
discussion
Bye.
very lively and very interactive. Thank you all. And we will be having that questions which were left, we will be having in our next webinar.
Much, ma'am. So can I share my screen, please?
Yes, ma'am. Yes, ma'am.
Are my slides seen?
No,
Yes,
no,
ma'am.
not yet.
Yes.
Are you
Yes,
Yes,
sure
ma'am. Now,
not seen?
now it is.
yes. Make it full screen, Dr. Anju.
Yeah, 1 second.
Yes.
Give me
Yes,
1
ma'am.
second. Yes. So this is my CV, which I am not going to repeat. So thank you very much for your kind introduction, Dr. Aarti. This topic which I'm going to talk is presented in a different manner. So I'm going to talk about how to age gracefully. So you all know that in aging gracefully is often used as a euphemism. Perhaps aging gracefully doesn't necessarily have to refer to age or appearance, but rather than attitude of people the people have as they grow through various stages of life. So it's very important for us to believe that what kind of attitude people have. So when we talk about this, some people feel that showing signs of aging but not powering, but still powering forward is in life is aging gracefully. Other feel that looking old but embracing it with grace is aging gracefully. And some women who choose to grow old that without undergoing any aesthetic procedure to help them maintain their looks is the definition for some as aging gracefully. This was earlier, but now what do women think about? It means that taking a step to make your outside appearance match the way you feel inside. If you feel energetic and youthful internally, then there is no shame in getting any kind of facelift, tummy tuck, or breast lift to keep your body at the same level as you were. Ultimately, it comes down to personal needs and desires. And if you are confident about getting plastic surgery, then electing to go under knife is most graceful choice you can make. So don't feel guilty about it. Just do what you feel is right for you. When we look at WHO's quality of deficiency, it is again an individual perception of their position in life in contrast to the culture, pani de do mujhe, culture and value system in which they live and in relation to their goals, expectations, standards, and concerns. So these domains can contain physical, psychological level of independence, social relationship, environment, spirituality, and religion, of course, personal beliefs.
Hello.
So let's start look into a different scenario which comes to us in day-to-day life. There is a executive officer. She's 47-year old. Her colleague had suffered from menopausal symptom. She thought she could beat up by consulting a doctor beforehand. She never had heard of film star ever suffering from any of these symptoms, and maybe their doctor prevent them from expecting menopausal symptoms. We all know that no one can avoid aging, but aging productivity is something else. And perimenopause is a natural stage of life. It's not a disease or a disorder. Therefore, it doesn't automatically require any kind of medical treatment. Now, when we come to the midlife and with advancing age, there is decline in immunity. There is risk factors accumulate, and further on, we are predisposed to chronic diseases. So there are multiple issues in menopause. It could start from abnormal uterine bleeding to vasomotor symptoms, problem with sleep, mood, depression, attractiveness, urinary complaint, GSM symptoms, and skeletal muscular problem and cognitive functioning. So
Technical team, mute everyone. Mute everyone.
Yes, ma'am, already done.
So we have to look for the window of opportunity and look that do and find out whether asymptomatic women need a therapy. Is there any role for them or a journal check? Go through a journal checkup like height, weight, BMI, waist circumference, hip circumference, blood pressure, breast examination, etc. And how far we go for the investigation and what about the screening and counseling and what about the hormone therapy. So in this patient, we have to do minimum complete blood picture, thyroid profile, blood sugar, lipid profile, pap smear, dental checkup. There is no place for FSH. TVS is not required if patient is not having any problem. Of course, BMD and ECG are essential only when a patient is obese and when she is suffering from any of the cardiovascular problems or a previous history. We all know that since ages, we have been talking of, everybody has been talking of immortality. Nobody wants to die. We have seen it from, I think, generations and generations. When Hiranyakashipu was there, he tried every level best to stay immortal. Then again came pyramids and other things. So people have been wanting to stay immortal, but I want to tell you that nobody has achieved this. But there have been a lot of change. We have now come to live with the added longevity. And there is an increased morbidity and disability, but this can we can with healthier lifestyle methods we can add years and also add longevity. So it's a cycle where we have to maintain our decrease morbidity and disability by having a healthier lifestyle and increase age. So what is healthy aging? It is compression of morbidity. And now what is compression of morbidity? So this term was coined way back in 1980 by James Price, and he said that most of the chronic illnesses occur near the end of the life. And if onset could be delayed, then healthy time saved could be less to lessen the burden of illness over the person's lifetime, and compression of morbidity occurs if age at the first appearance of disease can be delayed, leading to a longer life expectancy. Again, he said that limiting the time a person spends in a ill or infirm by postponing illness or once morbidity occurs by hastening death, largely due to preventive measures and healthy lifestyle, we can squeeze or compress the time of horizon between the onset of disability and death and maximize the healthy lifespan and minimize the time spent less than well. So a person is born and the person develops a morbidity at a particular age and then death occurs. So there is a particular time span. But with life expectation, if a person is not taking precautions, the morbidity may set in earlier and the time between morbidity and death is prolonged. This is not anybody wants. We want that the person should have the minimum time of morbidity onset to death so that you can have a healthier pre-morbidity time. This is known as compression of morbidity and it occurs with many factors. So how can we advise compression of morbidity and good quality of life? By preventive checkups, lifestyle modification, reduction in the risk behaviors, screening strategies, and appropriate medical care. And so is the older 70 is now new 50 and is new 90 is new 70. Yes, we all agree that now new 90 is new 70 for all of us, and we have a prolonged lifespan and we are living a much healthier life as compared to our predecessor. So how do we get it? By lifestyle modification, which can give us a good mental health, never smoke, no alcohol, good sun, lose weight, interventions in time, TKR, THR, and then if need be cataract, and also we can start statins and control your hypertension and diabetes. We all know the major risk factors all over the world is, all over the world is obesity. And this, we all know that when we talk of India, the obesity gets bigger in India, and there are more than 1 billion of people who are suffering from obesity, and they need to lose more than 25 kgs of weight per head. So it's a huge burden we are suffering. And India, what I could get was that India comes third in the world list of obesity. So we must zero down to control the obesity in our country and reduce the risk of all the morbidities which can occur because of the obesity. And when you look at the prevalence state-wise, you can see the red and the maroon places have a highest morbidity. So there are lots and lots of states which are having highest obesity and which we need to control. And today, the areas which may look red to you can become greener tomorrow, and the area which look greener or bluer can become orange, red. So we need to have a concentrated effort to start looking at preventing obesity from childhood. So another scenario which we can come across a 46-year-old asymptomatic obese woman who had never visited doctor, had her delivery 90 year earlier, visits you for weight loss. how will you assist her, help her? So we all know that in the perimenopause and menopause, there is a fat redistribution. And the fat from the hips goes to the waist within 1 year of menopause. And the waist circumference reflects the risk for cardiac vascular diseases. More than 72 centimeter is a great risk, and more than 80 is a greater risk. I'm sure all of us sitting in here have a highest risk for obesity and cardiovascular risk. So we must tell our patients, guide them, tell everybody around us to look for the waist ratio. Weight and BMI is not enough. We need to look into the waist hip ratio, which is very, very crucial to assess the cardiovascular health risk. We all know that there is a change from pear to apple, and apple share shape poses a greater risk because there is a redistribution of fat to the visceral fat, which is very, very highly uh, inflammatory and which can lead to all kinds of metabolic problem, starting with hypertriglyceridemia to insulin resistance and to all other problems, including sleep apnea. Again, as I said, I'm again reiterating that 73% of the Indians need to lose weight, and the maximum weight gain occurs at the age of 28 to 35 years. But sadly, recently we have seen the weight gain is increasing in the adolescents because of the fast foods and unhealthy habits, no exercise. And so that this shift is already started occurring. And as I said earlier, that we need to, on an average, we need to lose around 11 kgs, which is a very saddening news. And when we look at the uh, weight, how to maintain, we know that when the weight gain is, the BMI is between 25 to 30, we can work out with lifestyle modification like diet and exercise. But when the BMI is more than 30 to 40, we need to talk of pharmacotherapy. And beyond 40, we need to talk about bariatric surgery to control all the comorbidities. So, Dr. Maninder is already there. I want to stress upon the need of three-step management of menopause. Eat right, exercise, and medications. 80% of reduction in CVS can take place by diet and lifestyle changes as per the WHO, and it is very, very essential. When we talk of the exercise prevention, we need to include aerobic as well as muscle strengthening, breathing, and balance. 30 minutes of moderate intensity physical activity, mostly 5 days a week. Muscle strengthening at least 2 days a week. 30 minutes for fitness per day for fitness and reduce chronic disease. And 60 minutes for prevention of weight gain and 60 to 90 minutes to avoid weight gain. For women, they need to do a brisk walk, low impact aerobics, Tai Chi yoga, and we need to maintain this style throughout our life. Stop being lazy. It's only an hour a day. Running, brisk walking, swimming, yoga, meditation reduces insulin resistance, free radicals, and improves gut mobility. So, diet rich in fruits, fiber, vegetables, low intake in animal fats, carbs will lead to not only good health, but also lead to 70% reduction in the carcinoma of colon. So preventive strategies are better to control weight, normalization of BMI, and reduction of all cancer by 26%. So how do we manage other problems like cardiovascular disease, osteoporosis, breast cancer, diabetes, DVT, Alzheimer, endometrial cancer, and other ovarian cancer? We all know for DVT, for cardiovascular, we need to know about the age, family history, stress, hypertension, and obesity, and of course, high cholesterol levels. And we know that the incidence of CVD, when we compare with men and women with men, we know that as the age increases, the women go into their cardiovascular risk increases dramatically as compared to the men. So we can calculate the risk by fragment score, which considers age, total cholesterol, HDL, systolic blood pressure, smoker, and a score given with the risk of CAD for next 10 years. So another case, hot flashes, we all know that a woman can be asymptomatic except for hot flashes in a couple of months. She comes to us. She says, only hot flashes I have. She is hypothyroid on a thyroxine. Sister had a fracture with the BMI, which was less 18 only at the age of 54. So we all know that we have to do BMD in this patient. And if her T scores are less than 2, which we can see that she when we did her BMD, we found that she was in the osteopenia. So what do? We need to, as per the WHO osteoporosis diagnosis, any woman who's got osteopenia uh, can be managed with lifestyle and good diet. And we need to tell these women and even the medications. But if they develop osteoporosis or between T-score of minus 2.5 or lower, and a T-score of 2.5 and lower with severe osteoporosis, we need to give them medical treatment. So the evidence about the MHT with for bone health is that for age group of 50 to 59, HT is a safe and cost effective. It is definitely effective for prevention of osteoporosis related fractures. Even in a patients in low risk of fracture, uh, estrogen progesterone treatment for prevention and treatment of osteoporosis reduces the risk of all types of fractures, spine, hip, and other osteoporosis fracture by 30 to 40%. Hormone therapy for bone protection within 10 years of menopause is very good. But first line is always a diet rich in calcium and vitamin D, exercise to which will be help making the muscles and get the bones stronger when you use weight bearing exercises that force your body to work against gravity, walking, climbing, dancing, lifting weights, quit smoking, drink alcohol in moderation, cut back on salt and caffeine, bisphosphonates, teriparatide, and SERMs. Then aging can be fun if you lay back and enjoy it, but it is not possible for us. We know that because as we all said that all these women do not uh, we don't expect them that they are aging. But it was the Shri Devi who said that women over 40 should look after themselves and do not make them desirable just by doing a cosmetic surgery. They should have a inner power and also a good health per se, which is so very important. So here a woman comes to our clinic. She has a query. She is read in a magazine that Hema Malini had for undergone as cosmetic surgery to look young, and since she had been a model in her heydays, she wanted to prove that the world again wanted to know whether her chances were there. So what are the options available for her? We know Dr. Ragini is sitting in the audience. She would agree with me. There are multiple options. Sky is the limit. One can have brow lift, facelift, dimples, neck lift, bleptoplasty, rhinoplasty, botox, lip enhancer, threads, and mammoplasty, and so on. So now there is another woman who has come to us. She's lonely. She has her only son married, went abroad. She's in trouble of falling asleep, feels lost. How can we help her? We all know that she is suffering from emptiness syndrome. It is not a clinical condition that which can lead to, we know that lead to clinical depression. So we need to tell her, that counsel her, that she has to enjoy the personal space she has, seek a newer things like hobby, get friends of her own age, take world one step at a time, and sim she should we should look in her for symptom of irritability, fatigue, lack of interest, and appetite, mood swings. And we can treat her without medication if the person affected realizes her condition early. But if she comes to us in a late stage, in a depressive, acute, medical treatment could be required in her. Now, again, we all know that a woman can come to us for a problem in having an uncomfortable sex. Today only I saw one patient in my OPD. She had a hysterectomy, and they they initiated the process of itching. And when I went deeper, they came out that they have not been able to consume sex for long time. And when I went into the depth, I found out that she had her ovaries removed by a gynecologist at a very younger age, and she is suffering from severe GSM, which she has been sitting at home for, I think, God, for almost 12 years, and she was just 66, and she has not had sex for a long time. So we must ask a leading question and see how can we help her. We all know that the woman is not only suffering from hypoactive sexual desire, but also there is loss of estrogen and testosterone, and she may not be easily aroused, less sensitive to touching and stroking, drop in blood supply in vagina, and other contributory factors like bladder control problems, sleep depression and anxiety, and our medication. So we must help her with the treatment, and we can give her lubricants, moisturizers, vaginal estrogen in the form of cream, vaginal gel, and tablets. Change her medications if they are causing vaginal dryness, like antihistaminic, because people are consuming Montier LC in tons. They don't even know what are the side effects, and she should we should make it a point that she gets a proper sleep through either medical treatment or lifestyle management or drugs. Avoid alcohol, lose weight. Then we can give her osmorphine for her local dyspareunia, which can also help her in uh, other problems. We can give her sildenafil for this thing, her excitement problem, and also sexual practices, more foreplay, change of position, and communicate with her part. Tell her to communicate. We need to communicate with both the partners and tell them that how just staying closeness is more important than consuming the sex. Of course, we will help them in that, and she can even use the devices for vaginal dilatation gradually. That will also help. So we all know that age is inevitable, and but aging isn't. Another very common problem which we face is that a multinational woman, 43 years, uh, she found a time to think of becoming a mother at the age of 43. How will we help her? What are the issues she can face? We know that at this age, from the after the age of 35, her follicles fall at the rate of 9.1% per year, and that triples at 45 years. So aging oocyte with increasing aneuploids, roughly 50 to 70% of mature oocytes at the age of 80 for 40 years have chromosome abnormalities. FSH abnormalities are found at the women who come in the 40% of the women who come to us at the age of 40 years. And of course, they may suffer from other comorbidities. So, what will we advise? A natural conception, IUI, IVF, ovum donation, ICSI, surrogacy, depends on her reports and results. We can give her different options which are available for her, and we can give her supplementations also that can help her lower the load of gonadotropin requirement, and of course higher peaks of estrogen levels, increased number of retrieved oocytes, and also higher fertilization rate and more high quality embryos. So combination of L-carnitine and clomiphene may be given if patient has a good AMH, and it will significantly improve the ovulation rate, significantly improve the cumulative pregnancy rate. There is definitive role of IVF pregnancy. There is increased egg and embryo numbers, quality, reduced aneuploidy, reduced risk of miscarriages, shorter time of pregnancy, and increased spontaneous conception, improved cumulative pregnancy rate in patients and for who are. Now, this is a very common ad which a lot of people are using. What is it? We all know that there is a huge role of PRP which has been there with all of us using PRP is used to not only with they are basically with high level of platelets concentrate, but with growth factors concentration 3 to 5 times greater than plasma, and D3 FSH, LH estradiol, when we give, have been shown to improve by the activity PRP injection in ovarian tissue, but a lot of research is still required. Bone marrow derived stem cells also can help. So growing old is natural, but feeling old is not. So we all know that the decline in maximal, with the process of aging, there is decline in maximal function of vital organs. There is decline in reservoir power well before clinical visibility or limitation. A frail elderly subject is increasing concern for the individual without disease, mainly limited to organ reserve. So we all know that nobody can forever be young, because as we age, the kidney reserve, the heart reserve, all of them diminish and go to below level. And what is successful aging is that we need to stop the journey of uh, by of aging successfully by physically active and a good lifestyle, strong and local epigenetics, purpose and meaning of the life, and also environment that you live is very, very crucial. With that, we can always change the graph of life, as I have shown in the speaker. So know that you are each year is special and precautious for you, and shall only live it once. Be comfortable with growing older. Aging is an issue of mind over matter. If you don't mind, it doesn't matter. I believe that second half of one's life is meant to be better than the first half. The first half is finding out how you do it, and the second half is enjoy it. Getting old is like climbing a mountain and get little out of breath, but view it from a much better view. It is much better. So it should be a function of medicine to have people young as late as possible, as late as possible. So a young woman is a gift of nature, but an old woman is a work of art. Thank you very much.
Thank you very much, Dr. Anju Soni, for a very good and detailed insight into a graceful aging. And this compression of morbidities basically to maintain the quality of life of the woman. And you have covered very nicely all the aspects, from the mental health to the physical health, all her requirements, whether sexual or physical. And thank you so much for a very good.
Thank you.
Thank you, ma'am, for a wonderful lecture. Now I invite Dr. Jyoti Jaiswal, ma'am. She is one of the special guests of today's webinar. Welcome, ma'am, and want to hear few words of blessings from your side.
Thank you so much, Vishma. First of all, to involve me in this CME as a part of the national team and as a guest. But in front of you all, and especially with the presence of Singh Madam, I'm just Sangi Sathi and no guest here. I will like to talk little bit about the your theme of geriatric population and their management, for which you have chosen for this webinar. That is really commendable that you have thought of एक अलग से एक चीज choose करके आयो, which is not being covered by the other chairpersons and the other local programs which are going on. So first of all, congratulations for this, because it will definitely give a different kind of insight to all of us, that how with the so much of growing larger number of geriatric population, not only a postmenopausal, that comes after 47, 48 years, and rest 1/3 of all women comes under that category, and 1/3 of their lifespan. But this geriatric after 65 years, this particular age is also nearly 20-25% of the total population, which is being neglected actually, because so many things are taking importance, like in the period of childbearing age, and especially now menopause. Society has done lot of work, and I congratulate Dr. Anju Soni and all the predecessors of this Indian Menopause Society, that they had worked a lot, they had worked hard, and now the management of menopause is coming into the mainstream gradually. And at least in Raipur, I can say that everybody is well aware how to manage the menopause, and gradually we are also trying to bring the other fraternities, the medicine, the orthopedics, the neurology, and so many other fraternities, psychiatry, along with us as a common team for management of menopause. Geriatric definitely एक identified part है, उसके लिए अलग से clinics होते हैं, but still it is not up to the mark as the quality of life of the geriatric patients are concerned. So I'm very happy that this particular webinar and per se in general, and specifically uh, this panel discussion you have kept regarding geriatric health, and I think that it will help all of us. I wanted to talk a little bit about Maninder madam also, because she remains always very eager for talking in the geriatric care and the prevention of falls and osteoporosis. But currently I think she is in flight now, so she cannot join us. And I thank once again you, Anju Soni madam, Abha Singh madam, and Maninder madam, specifically both of them, because they have given me some enthusiasm and the motivation to work towards the menopause and geriatrics. Thank you.
Comprehensive geriatric healthcare. I want to invite expert for this session. First, I want to invite Dr. Maninder Ahuja ma'am. Ma'am is past president IMS. Ma'am is traveling, so ma'am has to leave us early. Dr. Sudha Sharma ma'am, vice president IMS. Secretary General IMS 2021-2022, former professor PG Department of Ops and Gynae, GMC, Jammu. Now I want to welcome moderators for this session. Dr. Ragini Agrawal ma'am, Secretary General elected IMS, National Joint Secretary IMS 2023. Dr. Shushma Verma ma'am, she is she's chairperson Digital Education Committee IMS.
Forward. I think over to Ragini Agrawal ma'am. Ma'am. Sanjita, invite all our panelists, please.
Now, panelist for this session is Dr. Jyoti Jaiswal ma'am, National Treasurer IMS. Dr. Ruchika Garg ma'am, Editor-in-Chief, Journal of Midlife IMS. Professor, Department Ops and Gynae, SN Medical College, Agra. Dr. Asha Jan ma'am, currently President RMS and Director of SMSA Hospital, Raipur. Medical Director, Cancer Prevention and Relief Society. Dr. Sonia Pariyal ma'am, she is Director and Consultant Psychiatrist at Dhanvantari Clinic in Shankar-Nagar, Raipur, and Chairperson of Indian Psychiatric Society. Dr. Shalini Jain Agrawal ma'am, she is Secretary RMS and Executive Member of ROGS, IFS, SFM, IAG. Dr. Ankur Singhal sir, currently working as Senior Consultant Joint Replacement and Reconstructive Orthopedic Surgeon at Ramkrishna Hospital, Raipur. and he is innovator of minimum cut technique. Dr. Tanushri Pitlawar, she is a consultant and HOD, pediatrics and neonatal physiotherapy and rehab at Kanha Hospital, Raipur, and she is certified antenatal postnatal physiotherapist.
Thank you, Sanjita, for a kind introduction and welcome.
Thank you so much, Sushma, for making me a part of this wonderful program. And I think after Dr. Anju Soni's talk, everything is crystal clear, and you have made a real geriatric panel with a multidisciplinary. We are seeing a physiotherapist, orthopedician, psychiatrist, everyone. So, we are not wasting any time. I'll just start with the panel, and the experts are, we have everyone there. Dr. Sudhaji is there, Jyoti, and Dr. Vipasa. So this beautiful panel is made by Sushma only, not by me. Why we are talking today about the comprehensive geriatric care? What is such a different thing when we are really in IMS no more talking about the prevention at the age of 45, 50, 55, but we are gradually we are going towards more 65 plus with the WHO new definition. The 65-year is a young old person. So this age group, when we are talking about the young old person, that means there's a middle old person, there's an old person. Even recently in the Lancet says we should not say anybody as a senior citizen until unless they cross 80. So this gives a message that woman is going to live a long time, and this long time is 3-4 decades of an adult life post menopause. And here, when we are talking about the menopause society, we have to look for these women for their other problems, not only the problem which is associated with the immediate menopause. So at present, the 81 years is taken as a average age, and even India, it is increased to 78.9. And today, one thing has more changed, that we are not talking about the disease all the time, we are talking about the quality of life. I think because of that, the most important thing which we have talked about the woman, as Dr. Anju has talked about in the last few slides, the body image, sexual health, these all things has become very important. So my first question goes to any of the panelists can talk about it. What are the main problem associated with the geriatric population? Any panelist?
Namaskar, Dr. Ragini.
Hello, Asha ji.
So I'll be the opening batsman. The major problem of geriatric population, I think, is mostly social. After that, from that social and depression, everything else is an adding up. So you will have, all पंचेंद्री हैं सब धीरे धीरे कमजोर होने लगती हैं. So that is the thing. You will have vision impairment, hearing loss, urinary incontinence, osteoarthritis, bone pain, vitamin deficiency, nutritional deficiencies, and you may have pre-existing diseases, and you are more prone to falls. But more than anything else, it is socially that people suffer most, which leads to depression, which leads to everything else. That is my experience as things go.
So thank you, Asha ji. It's a very precisely you have told the most important thing for the elderly person. We have to see her social existence. Our society is like that. If you are an older person, nobody bothers. Everything is made for the youngs. Even if you go to the gym, the coach is not ready to understand that you are an older woman, you are a fragile body, can have a lots of physical problem, osteoporosis is there, you cannot take lots of weight. So this is the understanding of the society as a social person, and your own existence is challenged. No doubt the other problem will, with the aging and with the loss of the estrogen, will come and make a problem for you. So that's why we talk about a comprehensive geriatric assessment. This we cannot see the in a single way that the person is visually impaired, or she is having a hearing loss, going to the ENT, then going to the eye specialist. What it will incur? It will incur the polypharmacy and the too many medicines, not a complete assessment of the patient. So any panelist can define what is a comprehensive geriatric assessment.
It is,
Yes,
hello,
ma'am.
Dr. Ragini, madam. It is a multidisciplinary approach towards any geriatric patient. His or her psychological needs, physical needs, social needs, as Dr. Asha said, and all the aspect, functional assessment, the caregivers, every aspect we need to touch, and then accordingly we need to make a plan of management for her and how she need to live peacefully and accepting the aging gracefully, all the needs, and according to that we need to make a plan.
So basically, when we talk about the comprehensive geriatric assessment, we are thinking something long-term goal. It has to be planned, has to be assessed, and it has to be reviewed in time and again planned with the age of the patient and the developing comorbidities. So it is an integrated plan, treatment, and with a follow-up. The follow-up is the most important part of this whole CGA. So, what are the goals of the comprehensive geriatric assessment to any panelist?
Ma'am, the goal would be basically that you identify a problem wherever it is correctable. It should be correctable. Wherever support is required, that support is given. So basically, you have a diagnosis of a problem, it has to be managed, and also you have to take the will of the patient. Whether they are looking for quality of life, whether they are looking for prolongation of life, and then you need to communicate what you're saying, because the language of a caregiver and the language of the care receiver may not be similar. So you need to have effective communication so they understand what you want from them, so that we can find out what is going wrong in their lives. That is important. So that we can help them live safely and happily in their old age, even if they are living, not with a lot of support. So even by themselves, they are able to exist in society.
Wonderful.
Can I add something? Excuse me. Yeah, I'm Dr. Ankur Singhal. I'm a joint replacement surgeon. Thank you for having me. Can I add something to this?
Yes, Dr. Ankur.
Yeah. So, as rightly said by Madam, it is very important that in this age group, we should listen to them. They only want listening. और मैं हमेशा बोलता हूँ, दो ही उम्र में आदमी बच्चे जैसा होता है, एक बचपन में एक बुढ़ापे में. So communication is very important. Everything has to be explained to them. You should listen to them. What are their problems, and then rectify them, because the main thing is communication. They are not being communicated properly, and that's why they get frustrated and have so many psychological problems because of that.
Dr. Ankur, I think you have to, your voice is not very clear.
Okay, just hold on.
The goal of the CGA is very clear. Number one, we have to looking forward the quality of life of an older person, and we are just going to give a support. If we diagnose some problem, we will elevate, but we have to think we are not going to make them fit for a marathon. Holistic management is a key for these patients.
Am I audible?
Yes.
Yeah, so that's what I was saying. Ki communication is very important. You have to listen to them and then rectify the problem according to the problems they have. So communication is very important, and we have to give time to them, which they dearly want at this age group.
Yeah, thank you, Dr. Ankur. Very rightly, you and Asha ji has give the what you have told. It is the essence of the whole CGA. So, what are the 5 components of the domains related to the CGA and how they work? Any of you can take.
So, ma'am.
So basically, it was clear when we talking about the comprehensive geriatric assessment. As such, anything what we say that physical health, mental health, social health, but here, as Asha ji has said, the social health plays a very, very big role, and the functional health. So, how we have to take it forward? This gold standard. Anyone? So basically, we have to assess that patient as her what is her functional health, whether she can functionally active for the daily life routine or a special routine. Means she can bath, she can brush, she can eat, she can walk, or she can handle her phone, she can go for shopping, she can cook her food. These all functional activities understanding is very, very important. Then the social.
Ragini, one thing I
Yes.
would like to add here, it's
Yes,
two
yes.
parts. One is your self-grooming and self-living, and the other is the ancillary activities that are required for life.
Yes.
Like driving, shopping, paying your bills, handling money, handling jewelry. So
very nice.
So for that, you have a questionnaire for one part and a questionnaire also for the second part. That is the comprehensive assessment that has to be done.
Yeah. So if you go to the internet, you will find there are many tools which are there for these daily living or this independent living. And there is a questionnaire. You can shorten it for your own OPD, your own need. And there's a scoring system is also available. So you can assess whether this patient is at which level. And basically, once the assessment is done, you have to stratify the problem. Identification of goal is must. And then you make a care plan, because this woman really wanted to live a life which is going to the party and all, or she would just want a happy life at home. And intervention, if it is really required, unnecessary, no intervention should be done at this age. And regular planned review. The essence is that every year she is becoming older and older. Maybe she is developing a new problem. So regular planned review is very necessary. To any of you, how can members of this whole team help in assessment of the various domain? What are the multidisciplinary team for assessment of the geriatric patient?
It's the physician, it's the part
There
of the
is
role of
generally a
the nurses
physician.
is very important. Yes, Dr. Ruchika.
Yeah, please continue, doctor.
Yeah, a physician is required for general cardiovascular health. Then we need a pharmacist, as you has already mentioned it. Polypharmacy is a very problem with them. जैसे कि अंजू मैम ने भी कहा था कि आप एंटीहिस्टामिनिक्स दे रहे हैं, उससे शी इज डेवलपिंग जेनाइटो-यूरिनरी प्रॉब्लम्स. देन पर्सनल केयर के लिए नर्सेस आर रिक्वायर्ड टू सपोर्ट देम. And for arthritis, physiotherapist help is required. And for the social support, the social group should be there to help them in their daily activities and for their good mental health.
The
So, and
occupational therapist, the physiotherapist, everyone is needed to they should make a team, and then they should make a plan, and they should make
for
a follow-up
for
Multidisciplinary
accordingly.
for
approach and
cardiovascular health and
having
for gait problems, a physician help should be required. A psychiatrist can also be
Then
required.
and we can,
For
after creating a multidisciplinary team, we can add few
dealing with
more
depression, stress, anxiety.
consultants and few more experts
yeah,
to deal with, such as speech therapist, dietitian, for adequate care of that geriatric population.
sometimes we need neurophysiologists physicians also to conglomerate the things.
So basically, we should not forget one thing. Most of these older patients, they are retired people. They have no source of income and they are dependent on their kids or anybody in the family. And for them, the economic burden is a big burden. That's why I think they will go in a shell and leads to many problems. This is a high time when this multidisciplinary clinic, like we have at adolescent health clinic, should come, and where all type of, because it's very difficult to take to them from one clinic to another hospital, where everyone is available in under one umbrella in at one place. And the most important thing is a social worker who is ready to talk to them, listen to them, and analyze the problem and present to the doctors or the therapists for these things. It is very, very important. So, Dr. Tanushri, you are the HOD physiotherapy. So, what is the role of the physiotherapist? We are talking about the physiotherapist management in this CGA. So, how this is the role of the physiotherapist, which I think is one of the most important part of a geriatric health. Your comment.
Hello, ma'am. Very good evening to all of you. Ma'am, as we discussed now, that geriatric care needs a holistic management. So here the physiotherapist plays a very important role in rehab care. What we do is we make a tailored exercise program for each and every elderly people needing uh, where we emphasize on functional mobility, improvement of balance and coordination, improving muscle strength and cognitive functions. What happens is also with the regular guided physical therapy, patient can improve their cardiovascular system, respiratory system, musculoskeletal, and cognitive functions also. So exercises like, I'm giving the few examples like trunk rotations, exercising involving midline, core strengthening, stretchings, all this can enable the elderly patients to regain their independence, preventing the risk of fall, maximizing their safety, and improving the quality of life. So the role of physiotherapy is very important. I also want to add, like in my opinion, why the elders should land in the risk. Why can't we make them a like compulsion that after a age of 60 years we can enroll them to the physiotherapy centers. We can plan guided exercises for them, and it will help with many like to prevent many risks like Parkinson's, Alzheimer's, dementia, osteoarthritis, etc. So it will help them a lot.
So very rightly said that when we think of the older women, the four major problem comes in the mind. Top is the musculoskeletal syndrome, that is weakening of the bones, osteoporosis, and the muscles, that is sarcopenia. What we call the osteosarcopenia, or the new word about for them is the musculoskeletal syndrome. For that, women need an exercise, and this exercise should be under the supervision of a qualified physiotherapist. So, role of a physiotherapy is very, very important at this age to prevent fall, to move. Even if she is not moving, it will lead to the gastric problems, social orchestration, increase in the mental health problem, which is already there. So it's a very important to have a good physiotherapist in the armamentarium. Any comment from anyone, or I will move forward? So, Dr. Ruchika, as you have commented that the cardiovascular health is very important in that population, can you elaborate, please?
Yeah.
What is prevalence? How we have to go about it?
Yeah, ma'am. According to the WHO data, about 70% of the women who are more than 70 years of age, they have some form of cardiovascular disease. Because we know that estrogen is cardioprotective, and after menopause, the protection which is offered by estrogen is lost. So, the incidence of cardiac diseases, which are less in women when they are premenopausal as compared to the men, they increases compared to the males after menopause. So 70% is a very big incidence.
Yeah. Even the cardiovascular event in the older women are more dangerous than the men. It is found in the studies. They have more chances of the cardiac rupture than the men. So what are the modifiable and the non-modifiable risk factor for the CVD in the geriatric population? Over to you, Dr. Shalini Jain.
various various modifiable factors are like, madam, genetic factors, her age, because she is aging, she is having hardening of the blood vessels, the female gender, the ethnicity, the Caucasian population, all these are non-modifiable, we cannot modify them. But if what other things which are modifiable are like her lipid profile, if it is altered, we can ask her to go for good lifestyle management. If she is having diabetes, so how to cope up with that, how to live with insulin resistance, we can tell them to do weight loss and exercises. Good muscle health will improve the insulin sensitivity, the dyslipidemias, all these things can be physical activity, all these things are modifiable.
So it is a few things in last decade has come up very clearly when we talk about the CVD, is that gestational hypertension and the gestational diabetes.
As well as polycystic ovarian syndrome.
So our women who are suffering during pregnancy with the GDM and the PIH, it's our duty to tell them, look, you are going to have more of the cardiovascular diseases. Specifically, now the girls are coming at the age of 35, 42 for the delivery. They are already entered in the perimenopause group or the so at least their checkup, early, yearly, the GTT, these things should be taught to them, that it is going to prevent their development of the CVD in future. Because once the vessels are hardened, atherosclerosis come up, it is very difficult to revert it back. So, Dr. Ruchika, again to you, what is the optimal level of blood pressure and the lipid required for the prevention of the CVD?
Yeah. The optimum blood pressure should be less than 120 by 80 millimeters of mercury. According to the American Heart Association guidelines, blood pressure more than 130 by 85 millimeter of mercury has been designated as hypertension. So our goal of treatment should be less than 120 milligram, and our optimum lipid targets are LDL should be less than 100 milligram, HDL should be generally more than 50, or if it's preferably if it is more than 60 milligram per deciliter, it's better. And cholesterol should be less than 200, and triglycerides should be less than 150 milligram per deciliter.
So many a time patient comes with a report and we see that report. Everything is normal. But if you see in the lipid, every other parameter is normal, only VLDL is 101. So these are the patient where you have to see that it is a start. Even in your PCOD patient, when you go for the test, everything comes normal, GTT is normal, insulin resistance is normal, everything is normal. But this LDL will give you indication that it is the earliest case of disturbance of the metabolic syndrome, or these are the patients who are going to develop the CVD in future. Dr. Asha, what is metabolic syndrome? I just tell you it's a start of the metabolic syndrome, how it affects the geriatric health.
Ma'am, metabolic syndrome is basically 5 different things. So here what is happening is that there is hypertension, there is dyslipidemia, there is insulin resistance, impaired glucose tolerance, and then there is central adiposity. All this has an effect on the cardiovascular system. It also has an effect on every activity of life, because as we know, insulin is a very, very important hormone, and metabolic syndrome starts with insulin resistance. When any 3 of these 5 are present, we call it metabolic syndrome. And what is happening is that there is hypertension, the figure is changing, the triglyceride levels are rising, the HDL is going down, and this happens even in PCOS cases. We see that this is happening, but these patients will have probably an early menopause. If it is pre-existing, then this is accelerated. There will be more of male type obesity in such patients. The cardiovascular risk is high. And what is happening is they lead to type 2 diabetes. Now, many studies have been done and they show that if there has been a surgical menopause, and after surgical menopause, the patient develops metabolic syndrome, HRT does not prevent it. But if there is a woman who has had a natural menopause and she is started on HRT, hormonal therapy, then there is a delay in development of metabolic syndrome. Why that's happening, we don't know, but there has been a study on more than 17,000 women, Asian women, and this has been proved. So let us be aware that ovaries are not wastage. Let us not take them out unnecessarily. So if menopause has occurred, then along with the other factors, this metabolic syndrome will lead to hypertension, frank hypertension, cardiovascular risk is increased, obesity is increased, and because of insulin resistance, the muscles keep getting weaker. There is sarcopenia, and then that whole triad of, weak muscles, weak bones, fall, fractures, injury, decreased quality of life, all that whole thing comes into play, along with the cardiovascular risk factors. Obesity is a compounding factor in all of these.
Thank you, Ashaji. Sudhaji, we want a comment from you on this particular topic.
Very well summarized, Dr. Asha. Yes, metabolic syndrome is a huge problem. We all know two factors present out of three is, metabolic syndrome. And as we grow, as we, attain menopause, as we age, our, the adiposities that increases, especially periumbilical area. So when the periumbilical area, pear-shaped body becomes apple-shaped, then, there is visceral adiposity, and that is the main risk for everything. I think she has very well narrated it, but they say that if you give menopausal hormonal therapy in patients who are, younger, 10-year, less than 10-year postmenopausal or less than 60 years, in those age group, the menopausal hormonal therapy is beneficial as far as heart is concerned, bone and everything, every system is concerned, because baseline heart is better. There is no atherosclerosis. The carotid media and rima thickness is better, and calcium scoring is also better. So at that point of time, if you give, it is beneficial. But no organization, no society has given any indication of menopausal hormonal therapy in metabolic syndrome. So guidelines, they say that once the metabolic syndrome has been established, no menopausal hormonal therapy to be given that would harm rather than doing a benefit.
One line I would add.
I think we should move to the next question.
Madam.
Yes, Dr. Vipasha.
Yes, actually, in line with Dr. Sudha's comment, that MHT is not going to benefit an established case of metabolic syndrome, and also the reason why the cardiovascular emergencies are more in postmenopausal women compared to men of that age group. The both things have got the same answer, because the beneficial effect of estrogen on our body. Women are actually benefited by the effect of estrogen till menopause, because estrogen has got so many effects on it, affects lipid metabolism positively, insulin metabolism positively, and in a positive way. And also this on cardiac endothelium, vascular endothelium, there is nitric acid. It enhances nitric oxide production by endothelial cells, and that affects that results to vasodilation. And on the other hand, in case of men, the effect of aging is gradual, and so the effect of harmful effect on cardiovascular system. But in women, the effect is rather quick. Not so. Am I audible? Am I audible?
Yes. Yes, Dr. Vipasha.
Yes, actually, in case of women, the change is very quick, rather quick compared to men. And as soon as menopause starts, or during perimenopausal years also, the beneficial effect of estrogen very quickly go off, and that's why. And at the same time, the macrophage, the lipid-laden macrophage cells, which are foam cells, they adhere to the cardiac, the damaged portion of cardiac endothelium, and start producing inflammatory products like cytokines. These are actually the preliminary, this thing of atherosclerotic plaque. And as women are used to have beneficial effect of estrogen till the age of menopause or perimenopause, and quickly the effect of estrogen goes off, in their case, the atherosclerotic plaque are more vulnerable to rupture very quickly. That's why cardiovascular emergency is more in postmenopausal women than to men, who are gradually adapted. Who in case of men, their cardiovascular system is gradually adapted, but in women the time is much less. And also why the MHT is not beneficial when in an established case of atherosclerosis is the same answer. Because if we use MHT in younger age, within 6 years of menopause, or within less than 60 years, it helps prevention of development of atherosclerotic plaque due to its beneficial effect on lipid metabolism and also on the vascular endothelium. If once the atherosclerotic plaque are formed, then there is no question of giving MHT. It is not going to benefit in any way. Rather, it may be harmful. That is the reason.
Okay.
And another point, a few slides back, when you were talking of multidisciplinary care of this thing of a geriatric patient, elderly women, or occupational therapist, physiotherapist, and all. I want to make one comment, that presence of a family member all along makes them more happy, because even if we are very well off, we can keep our mother in a good setup of with all these disciplinary, all these occupational therapists, physiotherapist, physician, nurses, and all. Presence of a family member throughout, or as long as frequently as possible, makes the situation much better for them. This is my comment.
I think we have to move forward. Ragini ma'am, can you ask the next question? I think we can skip this one. This question.
So, what are the steps to be taken to reduce the risk of the primary cardiovascular disease, Dr. Ruchika?
Yeah, ma'am. As already discussed, stress is an important factor for cardiovascular disease. So there should be changes in the lifestyle, beginning with reduce smoking, moderation of alcohol intake, reduce stress in life, and maintaining an optimum body weight. So, and avoiding a sedentary lifestyle. So for weight maintenance, ideally, as we have seen that metabolic syndrome is an important precursor for cardiovascular disease. So 150 minutes of per week of moderate intensity exercise, or 75 minutes of vigorous exercise can be done. So moderate intensity exercise or resistance training can include swimming, walking, and
Okay.
special concern on diet with less of saturated fat and more of nuts, whole grains in the diet. And we all know the importance of fiber, fruits,
Okay, ma'am.
and vegetables in our diet. And I would like to emphasize the importance of sleep, which is very important.
Then,
So
ma'am, we should move forward for our questions on mental health.
So basically, we have to see all those preventive drug regimes, lifestyle modifications. So coming to the most important thing, what we talk about, the cerebral fog, mental fog, and we all know that the estrogen has lots of effect on the neurotransmitter. So we have a neuropsychiatric with us, Dr. Sonia Pariyal. So Dr. Sonia, we want to know what are the various psychiatric problems seen in the geriatric population and what is its burden?
You see, nearly 17 to 20% of our geriatric population is suffering from some sort of psychiatric issue. Among the commonest that you get to see are depression, anxiety disorder, mild cognitive impairment, dementia, and sleep disorders. Now, what I would like to specify today in the limited time that we have at the end, that most of these disorders in geriatric population go undiagnosed. A lot of underdiagnosis simply because the geriatric population has significant amount of barriers to reach out to a psychiatrist straight away. So what we discussed earlier, that the team that we have formed, that team has to be very alert to diagnose these issues. Now, depression usually is not presented by the patient, our geriatric women especially, in the routine form of low mood, It won't come about directly that way. It's going to be presented in a very different manner. High degree of somatization, high degree of change of, energy levels. Many of them would be reporting a lot of fatigue, and you're not able to explain it by your other medical disorders. The morbidity of the other disorders itself contributes to depression and anxiety disorders. So a lot of underdiagnosis simply because of the presentation, which is a little different from the depression presentation in the younger population. So we really need to be alert, and the first line of diagnosis has to be made by our obstetricians and physicians who have to be alert if they find a sudden change in functioning of the disorder. Functionality, if it has come down, if there is significant sleep disturbance, and you suddenly find her somatizing a lot, just get alert. Are there any other psychiatric issues which are being neglected? Now, depression, like many of us, we tend to think that it's a part of old age. She has a lot of stress. She's lost her husband recently. Obviously, she's going to be depressed. Her children have left. So she's going to be depressed. We tend to take it as a part of a normal aging. And actually, it's not that. Depression itself is a full-blown medical disorder. And it has high amount of comorbidity with cardiovascular disorders. Suppose if she has CVD, she has obesity, she's suffering from metabolic disorders, these women are going to be more vulnerable to depression. As a part of the medical syndrome, we really need to address it and treat it medically as well. Then the other unique part that I would like to point out, which we generally tend to miss, is the unique, very different social situations that our women are facing now. Especially in the Indian scenario, I would like to highlight, most of our women are in the from the rural population. Most of them are financially not independent. They don't even have the basic primary mental health care available for them. So we are missing out on this huge, large population of old age women living in the villages, not even getting basic medical care, forget about mental health care. And then this sudden loss of social support systems. We had huge joint families. They have suddenly disappeared. The empty-nest syndrome that somebody highlighted, one of our speakers very rightly, rural to urban migration, and then from India going abroad, we are seeing suddenly in our clinic a whole landscape change where women are being found very lonely, having no support systems, and that's a significant social stressor contributing to depression. And then again, this sleep disorder, which is being so prominently seen in our geriatric population. They're so anxious that sleep is part of depression and anxiety as well. It's a presentation of early onset of dementia as well. So many of these are so much interrelated. And if there is a past history of depression or anxiety or sleep disorder, it definitely worsens postmenopausal. because estrogen was the protection, the protective hormone for mental health earlier. And this sudden loss of estrogen also contributes to a high degree of psychiatric morbidity, which is unfortunately unaddressed. And I want to highlight one thing very prominently. We are so averse to using medications in this population. Everybody would say, just talk to her, just provide her that connection. She might feel better. No, if she's depressed, it's a medical disorder. You need to use the right sort of molecules at the right time. Of course, avoid using benzodiazepines. I see so many of our senior physicians just prescribing alprazolam or clonazepam, just to address the sleep disorder or depression, which of course should be avoided because benzodiazepine overuse is a big issue in the geriatric population. They tend to abuse, it causes more cognitive impairments, and we really need to avoid them. Instead, select the right molecules with the help of a psychiatrist. SSRIs are quite safe, SNRIs are quite safe, but the stigma associated has to be cut down, and we have to be more willing to consult them and reach out to them through our support networks. Yes, providing them the right collaboration with the social NGOs that are available, who can reach out to them, go to their homes, connect with them, because really it's not possible for them to reach out. So many a times a psychiatrist and a counselor could do a lot good to these patients, especially our geriatric population.
Thank you, ma'am. Thank
so
you very
much,
much.
Dr. Sonia. It's
And,
a wonderful thing to address their mental health in a time. This is the crux of the thing, and we should not hesitate to take our help. So thank you, every panelist. Now I will hand over to my co-moderator, the Dr. Sushma, to take forward this panel, very, very important panel. Over to you, Dr. Sushma.
okay, ma'am. This was the question to Dr. Jyoti Jaiswal. What are the factors which affect the bone mass? As we know, there is loss of bone mass in the old age, along with the loss of muscle mass. Dr. Jyoti, can you hear us? Are you there?
I don't think she's there.
Okay.
Dr. Sudha is there. She can easily take. She has written a book
yes,
also.
ma'am, you can answer this.
Yes, Dr. Sushma.
Yes, ma'am.
Bone mass, achieving the best bone mass that we call as the bone mineral density is, the goal. It should be the goal by all of us, and it has to be achieved, in early age. The maximum bone mass is achieved by the age of 30 years. After 30 years, there is a plateau, and then there is a fall in the bone mass. And in, menopause, once we attain the menopause, there is 2 to 4% loss for first 5 to 10 years. So the bone mass will depend upon various factors. The genetic is the most important. Racial, we, Asian people, we are small built people. We have, less bone mass as compared to our Western counterparts. Then the healthy lifestyles, calcium intake, vitamin D intake, nutrition. Rather, it should start right from in utero. In utero, that means what is the diet of the mother? Lot of calcium and vitamin D if taken in utero, because bone formation is at that point of time. And we have seen that small for dates babies, they have, decreased bone mass later in life, and they have, more chances of having fracture in their 70s. So that is because of, if you do not have an effective and good diet during intrauterine life. So the peak bone mass, the bone mass starts right from the intrauterine life. Then, during adolescence, and then, you gain up to 30 years of it. Then you have, certain modifiable factors and certain non-modifiable factors. So non-modifiable is the increasing age, menopause, race. If you have, fracture, previous history of fracture or history of fracture in the family, then you cannot do anything. But certainly we have, some factors which could be modifiable, right? Increase physical activity, stop smoking, alcohol abuse, then, gain, maintain good weight, very low BMI people, they have small bones, they have thin bones. So all these factors, vitamin D, they will help formation of good bone mass.
Thank you, ma'am, for a wonderful elaboration of these factors affecting the bone mass. We are running short of time, so we are moving forward for our next question. So the important musculoskeletal issues which are related to menopause are osteoporosis, sarcopenia and frailty, and osteoarthritis. So my question is to Dr. Ankur Singhal. So that uh, how a orthopedician manage a bone and joint problem in the geriatric age group?
So usually when I see patients with joint pain, especially females, perimenopausal, postmenopausal, I always make sure that I ask the history also. Two histories are very important because I've seen patients who have early joint pain are those who have either early menopause or those who have got their uterus removed. So I ask them if they have a history of early menopause in their family as well. And if the answer is yes, the chances are very high that they should take care of their bones at a very early period of life. So I've seen patients because of the hormonal changes, they gain weight, their joint pain increases post menopause. So these are the problems which I face, especially during the menopausal age groups. So if I am operating a patient who has grade 4 arthritis in an early stage, in an early age, sorry, so she might be having early menopause. That is the common reason because why she has so much joint pain at a very early stage and grade 4 arthritis. And regarding in geriatric population, uh, as ma'am said, it is very important that you should maintain your weight. Always 6 monthly get your vitamin D and B12 also. So B12 is a very important vitamin. I've seen patients who have polyarthralgia and multiple joint pains, which they think of rheumatoid, but it is because of hypovitaminosis, decreased vitamin B12 and D levels. So 6 monthly get your vitamin B12 D levels done, because I have seen patients who have decreased vitamin B12 levels. They have suffered from myalgia as well as psychosocial problems, tingling, numbness, and other neurological problems as well. So vitamin B12 is very important. And I also tell them if they are, nearing geriatric age group, to lose their weight, eat healthy. Most of the vegetarian population, they don't drink milk. Vitamin B12 is the only source. Milk is the only source of vitamin B12 in vegetarian population. And even the ground level water is important because most of the homes have, RO waters, which results in decreased vitamin B12 levels. So these vitamin maintenance of these vitamin levels are important. Eat healthy, take care of your joints, and try to show to an expert early so that the progression doesn't happen. Most of the patients who come to at a later stage of life when they have already deformed knees, so it is always better if you can show to an expert in an early stage so that we can manage your joint problems and prevent it from increasing.
Thank you, sir. Thank you very much for your opinion regarding the old geriatric bone and muscular problem in geriatric population. So these are the various factors which Dr. Akbar has already said about the how to maintain the adequate bone mass and bone health. So now we are moving to a very important question about
I just
how
want
to
to
prevent
answer in that
fall
also.
in elderly population.
Yeah. So as Sushma ma'am rightly mentioned in this slide, I also recommend patients who are at a geriatric age group at home. There should be a home should be well lighted. There should not be any littering around, especially when there are kids around. Toys, all those things can result in fall. Most of the patients of the age group 70 or 80 who comes to us have a fall during night. So it is very important that in the bathroom also you should have railings around. You should have a support to, because patients who get lift themselves off from the commode, then only there is a stress riser on the hip joint and then results in fracture. So it is very important that your room should be dry. There should be a firm mattress outside the bathroom, and there should be a something, a railing type sort of thing which should be there in the bathroom so that they can hold it and prevent them from falling. It is very important.
Very rightly said. And these are the few tips uh, to prevent falls. That is, talk to your healthcare provider about the medication and their side effects. Make your home safer by using night lights, installing grab bars in the bathroom, and securing carpet to the floor. Stand up slowly and avoid to avoid dizziness. Do strength and balance exercises. Get your vision and hearing checked regularly, and use a cane or walker if you need more stability. So we are already running short of time, so we have to conclude our panel. So these are the few take-home messages which I want to highlight regarding each and every geriatric population. Consider each geriatric person as in individuality, and consult his preferences. Be patient, kind, and sympathetic. Communicate effectively and demonstrate respect. Encourage independence and encourage him to make choices and decisions. Assist elderly to achieve emotional stability. Stimulate mental equity, sensory inputs, and physical activity to uplift their self-esteem, self-concept, and confidence. Make elderly stay in home interesting and lively. Provide diversion and occupational therapy. Maintain their privacy. Handle them gently. Make them comfortable by providing comfortable bed linen. Keep bed dry, smooth, and unwrinkled. Encourage them to maintain body hygiene and the body temperature. Assist them to take care of their visual, auditory, and dental problems. Protect from injuries, falls, and accidents. Ensure adequate nutrition. Facilitate elimination. Encourage them to maintain hygiene of the external genitalia. So, by such take-home messages, what we are going to have, the objectives of geriatric health. By the above take-home messages, we can maintain the healthy functioning of the geriatric population.
Ritu,
Disease can be detected at an early stage. Prevention of deterioration of any existing problems can be prevented. As Dr. Anju has already said, preventing illness was expressed by Mr. J.S. Rice as compression of morbidity. We should live a relatively healthy lives and compress the illness a short period of time before death. So, love and respect old age people because you are aging too. So thank you very much, ma'am. And